All right, here we go. Summer 2020. It is Monday, week 6, endocrinology. Off we go. Today we're going to start to talk about Cushing syndrome and glucocorticoids. This is the star of the show today. Glucocorticoids, of course, are released from the zona fasciculata of the adrenal gland. They normally, of course, are released in response to the release of ACTH, really POMC ACTH. And ACTH binds with fasciculata cells and stimulates that mechanism. Real glucocorticoids, non-synthetic ones, are members of the HPA axis, the hypothalamic pituitary adrenal axis. I think we know that stuff. They have all sorts of functions. A big one is carbohydrate metabolism. We've already talked quite a bit about how stress can suck glucose out of your system, and it needs to be replaced. How is it replaced? Glucocorticoids are released, namely cortisol is released from the adrenal gland, and it stimulates gluconeogenesis and makes you some more blood glucose. It also affects protein metabolism, fat metabolism. It defends against stress. It defends against inflammation as well. Cortisol, of course, is the main glucocorticoid. It exerts 95% of all glucocorticoid activity, has a significant mineral corticoid effect. I think we talked about how it does act like aldosterone a little bit. And it can bind to the MR receptors, the mineralocorticoid receptors, although it doesn't have a great affinity for those receptors, meaning it's a little bit harder for cortisol to actually bind to an MR receptor compared to aldosterone binds to it lickety-split. So it has some trouble, but it can bind to it. Interestingly, though, on the other hand, the plasma concentrations of cortisol are 2,000 times that of aldosterone. So there's a lot of it around. And there's the molecule there of cortisol. I expect you to know that and be able to draw that for me on the test. I'm just kidding. Biochemistry, you might have to draw that, though. 90% of cortisol is carried bound to globulin, but 10% of it floats freely, and that is the most active, the most potent cortisol is the one that doesn't get carried around the bloodstream. Of course, cortisol binds with, we know, MR receptors, but who are its receptors, which have high affinity for it? They're called alpha glucocorticoid receptors, or you can just call them GR receptors, or they're called type 2 corticosteroid receptors by some authors, and they are not on the cell membrane. What? How can that be? How can you bind to a cell, but the receptor's not in the cell membrane? Who's got the answer to that? I bet Josh has the answer to that. See, I'm learning who asks the questions. That's right. Good, Josh. Josh knew the answer. Or am I thinking of the wrong name now? No, I think I got the right name. I'm starting to mix my classes up, so. The cortisol is a steroid, right? It can float right through the cell membrane. It doesn't need a receptor. It floats right through. So its receptors, its GR receptors live inside, floating around in the cytosol. And once it binds, the two go hand in hand, and they go into the nucleus, and they impart some change. Heat shock proteins, you've probably heard about those. I'm sure you've had biology classes. They talk about those. They cover the binding sites until cortisol shows up, or aldosterone. If enough aldosterone pounds on them, depending on where it is, it can remove that as well. It's like a shield, like a little cover for the receptors. Not good to have mutations of those things where they don't come unbound. I won't get into that one, though. Cortisol does not bind to beta glucocorticoid receptors. It only binds to alpha glucocorticoid receptors. And as noted, it can certainly bind to MR receptors. Cortisol and the kidney. Because I know what you're thinking, oh no, if cortisol can bind to MR receptors, what about the principal cells? We're going to have all kinds of crazy effects. Right? So we're going to have hypertension all the time, especially when we're stressed out. No, that's not the way it works because of a very important enzyme called 11-beta hydroxysteroid dehydrogenase type 2. Or how about just 11B HSD2? Super important enzyme. In fact, if you would have kind of hyperaldosterone symptoms if you had a mutation of this, because cortisol would be binding to those receptors of the principal cells and acting like aldosterone. But fortunately, it's a strong, tough gene, and it doesn't usually have trouble. All right, so 11-beta HSD2 binds to cortisol in the kidney. Yeah, what does this thing do? Right? So it's an enzyme, but what does it do? Who's its ligand? Its ligand is cortisol. And in the kidney, when cortisol comes in around the kidney cells into the interstitium, is floated around looking to bind into principal cells, it finds 11B HSD2, and that binds, kind of soaks up the cortisol. And what it does, because it can't just bind and latch onto it, it has to create something. So it cleaves off part of its tail and creates the hormone cortisone. And cortisone is a steroid as well, but it has no effect or very little effect on the principal cells. So it can't bind to the MR receptors that are on principal cells. Who cares about 11B HSD2? Well, patients who have AMES, AMES, sometimes it's just called AME, but that's called apparent mineralocorticoid excess syndrome. So it's super rare because it's autosomal recessive, not dominant. That means that both your mom and your dad would have to have the mutated gene for 11B HSD2, and they both passed it on to you. So if both of your genes are mutated, or both of your 11-beta HSD2 genes are mutated, then you have a problem. The cortisol that gets inside the kidney and is about to bind to the principal cell will not be turned into cortisone, right? Because 11B HSD2 is mutated and it doesn't work very good. And so you do get an overstimulation and overbinding of the principal cells, and you act like you have hyperaldosteronism. So that's not a good thing, and that can be confusing. So it acts like hyperaldosteronism. There's one huge difference, though, when you do blood work. So when you do blood work, you're going to, just like hyperaldosteronism, you're going to find hypertension from the over-reabsorption of salt and water. You're going to have hypokalemia. Too much potassium got kicked out. Too much hydrogen ion gets kicked out. You're going to have metabolic acidosis. You're going to have low renin levels because of the hypertension. You are going to, here's the difference though. With hyperaldosteronism, you're going to have too much aldosterone. But when you measure blood work, you're going to have normal levels or even low levels of aldosterone. So that's the difference. That's how you can tell the difference between AMEs and hyperaldosteronism. Everybody good with that? I do like that question. Licorice. I like licorice. Licorice is fun. But if you go crazy, I mean, you would have to eat like a pack a day of licorice, but some people, especially people with mental problems, they eat crazy amounts of licorice, and you can have a problem from that. In fact, it can induce AMES. And how does that work? So licorice, real licorice, not the fake stuff, but real licorice can convert or the bio, we won't get into the exact mechanism, but the biomolecules within licorice can be converted into something called glycerinotinic acid. Glycerinotinic acid. I think Rin Tin Tin, that show about the German Shepherd, but it's really glycerinotinic acid. So what? So glycerinotinic acid blocks the enzyme activity of 11B-HSD2. So it shuts off 11-HSD2. So what? Well, that's what soaks up the cortisol and turns the cortisol into cortisone, and that's what saves the principal cells from being affected by cortisone. And so now you don't have that, so you start to develop hyperaldosterone-like syndrome or symptoms, but technically it would be AME type symptoms. Why? Because when they check your blood, your aldosterone won't be high. Okay, let's meet the glucocorticoids. I think we've talked about these. Cortisol, aka is hydrocortisone, is an aka for that. And this is 95%. This is the main glucocorticoid. Corticosterone is weird. It's not super potent, but it does have a little bit of an effect. It accounts for about 4% of glucocorticoid activity. But what's weird about corticosterone, we've seen it before when we make aldosterone. So there it is in the aldosterone pathway. And yeah, it's even though it's one step away from aldosterone, it's considered a glucocorticoid with cortisol. So that's kind of strange. Let's meet some of the only other glucocorticoid natural one is cortisone, which is less potent. Again, that's the one that's converted into by 11B-HSD2 from cortisol. Now we have some synthetics that you should be familiar with because they may show up in your patient intake forms. We have prednisone. We have methylprednisolone. Prednisone is the classic one for sciatica and chronic back pain. Primary docs know that one and do prescribe it. It's 4 times as potent as cortisol, so it's much stronger. Methylprednisolone is 5 times. It's about like prednisone. It's got an extra methyl group on the molecule. Dexamethasone is no joke. This one is 30 times as powerful as cortisol. This one often is used in epidural steroid injections, so super powerful. And then hydrocortisone, we've talked about that. It's the least potent, but it can be managed quite well. People who are on this stuff all the time often take this one. Okay, they were used for treatment. The first disease treated by glucocorticoids was rheumatoid arthritis. Not commonly used for all sorts of now they're commonly used for all sorts of inflammatory conditions. You name it. Chronic osteoarthritis, ankylosing spondylitis. They're all over the place. How do glucocorticoids knock out inflammation anyway? Well, we've looked at that. There's genomic and non-genomic mechanisms, how like prednisone, but all glucocorticoids can snuff out inflammation. So let's look at these genomic effects first. So they turn off the genes in inflammatory cells like macrophage. We know macrophage from our studies of inflammation release cells or release molecules that call in the rest of the troops, the neutrophils, the basophils, the eosinophils, the lymphocytes, the troops that are there to fight bugs and fight inflammation or fight infection of bugs mainly. They're also called in to fix damaged tissue. If you've ripped up some of your tissue, it's got to be cleaned. And the troops are called in to fix that up as well. So cortisol can bind with, like macrophage has receptors for it, and it shuts off the ability to release the big one here, tumor necrosis factor alpha, and the interleukins, interferon. So that's one important mechanism. It also turns off arachidonic acid, as we already know. How does it do that? That's the first step of the inflammatory cascade, right? It binds to phospholipase A2 and inhibits it so you can't make arachidonic acid from damaged endothelial cells or endothelial cells involved in the infection or that have been damaged by trauma. They can't get inflammation going. I mean, by this time, this mechanism has already been going, but it's been going for too long. Body usually runs inflammation way too long. And so now you need to shut off that inflammatory cascade by knocking out phospholipase A2. It also turns on some anti-inflammatory cytokines, interleukin-10, lipocortin-1, and NF-κB inhibitor are anti-inflammatory cytokines which inhibit the pro-inflammatory cytokines, and without pro-inflammatory cytokines, you can't call in the troops. Remember this thing, so just to show you, we've already talked about this. Was it in this class? I think it was in this class. Or was it in, yeah, it was in this class. So remember phospholipids, if you have an injury and you damage tissue, and if you damage tissue, you've damaged the microcirculation, right? It's inextricably bound to tissue is the microcirculation. So you've damaged that, and the damaged cells specifically release phospholipids, and phospholipase A2 turns that into arachidonic acid. Arachidonic acid, if we go either one of these directions, can be turned into prostaglandins by the enzyme PGH2, and then prostaglandins can be by a whole bunch of different PGHs and PGEs, a whole bunch of different prostaglandin enzymes can break it down into inflammation, pain, fever. Gastric mucosal barrier, we talked about PGE2. PGE2 is made from prostaglandins as well. So I'm not going to go over this whole thing again, but it's cut right at the root. It does not let arachidonic acid turn into leukotrienes or into prostaglandins, so you snuff out all this stuff. So very powerful type of anti-inflammatory. What about cortisol versus inflammation? Other mechanisms. Another one, this is out of Guyton, so it's there. It's important stuff. So remember, lysosomes that are inside cells are very impotent. They're like little stomachs, right? They can digest all sorts of stuff. In part of the inflammatory cascade, cells are blown up or destroyed, and the lysosomes are destroyed, and it releases those digestive enzymes into the tissue, which is great if you're fighting bugs, but if the infection is pretty much over, it can destroy tissue. And so cortisol will toughen the membrane around lysosomes. So if the cell is blown up, the lysosome won't explode. So it keeps those nasty, destructive substances inside the lysosome. It also decreases capillary permeability. Remember, inflammation via histamine and other mechanisms causes the endothelial cells to shrink in the microcirculation, and and blood fluid comes pouring into the interstitium, and makes it easier for the troops to get in there as well. And so this causes decreased capillary permeability, and the endothelial cells are pulled closer together, so it's harder for the troops to come. First of all, it decreases the swelling, but it's harder for more troops to come into the area if the permeability is decreased. If there's a fever involved, it attenuates the fever by knocking out interleukin, so it cuts back on the fever by knocking out interleukin-1. Interleukin-1 was produced, I added that over on this side, that's produced by the leukotriene pathway. And so, leukotrienes will increase via leukotriene-1 will increase fever. It goes up to the thalamus and stimulates that. But you knock that out as well. More adverse effects of glucocorticoids. Well, we know they, just like COX-1, it knocks out PGE2, so there goes your gastromucosal barrier. So some people have a very difficult time taking prednisone and things like that on a long time because their stomach can't stand it. And then this is interesting, the taking of exogenous glucocorticoids like prednisone, if you take even physiological level, but usually physiological level is about 6 milligrams, it's equivalent to 6 milligrams of prednisone is about a physiological level of glucocorticoids. So many people are on 20, 30 milligrams to keep their inflammation, their bone-destroying inflammation in check. And so that can result in Cushing syndrome, which is where we're going. We haven't talked about that, I don't think. So, and if that's not bad enough, so you start developing Cushing syndrome, and the doc says, okay, we got to take you off it. We got to take you off. So you try to wean off, And then we know from the last lecture that sometimes the machinery that makes cortisol and makes ACTH and CRH, that machinery sometimes permanently damaged, and it doesn't come back, or it can take a year or 2 years to come back on. And so then you go from Cushing's to going into adrenal insufficiency. So glucocorticoids have to be used very sparingly. You should never take them unless you're really, really acute and disabled, and because they do have negative sequelae, as we've learned. Fun facts: glucocorticoids have both glucocorticoid and mineralocorticoid activity. Yeah, really simple question. Hydrocortisone in particular has a lot of mineralocorticoid activity. The powerful one, dexamethasone, has zero mineralocorticoid activity. So that would be terrible to give dexamethasone to someone who has primary adrenal insufficiency, because they need that mineralocorticoid activity to take the place of aldosterone. All right. What about stress? One of the key things of jobs of glucocorticoids is to make sure we have enough blood glucose levels. I've said that a million times. Caveman's running away from a saber-toothed tiger. Oh my gosh, all his blood sugar is soaked right up. Where's it going to come from? Glycogen stores are going to be tapped, and those are going to run out quick, so you need to secrete cortisol to stimulate gluconeogenesis. That's one of the huge stimulators of gluconeogenesis is cortisol. And gluconeogenesis can rapidly get glucose back into the bloodstream, and that's what it does. What are the stressful events? I think we've talked about them before, but some major type of trauma: you break your femur, you break your back, a big infection, chronic exposure to heat. These are Guyton's list: heat or cold. So if you're freezing to death, surgery, severe illness, chronic confinement, like prisoners in solitary confinement, chronic or severe psychological stress. I had to add that in there, Guyton. Sorry about that, but that's definitely a glucose-sucking stress event, according to many other authors. They didn't list that one, though. So how does that work? And we know this already. Stress events suck up glucose and glycogen like crazy. And if you don't replace that glucose, you're going to go into hypoglycemic shock. So what's the body going to do? Well, it's going to make more glucose, as we said, via secreting cortisol from zona fasciculata. By this, I shouldn't have to say this again, CRH, POMC to ACTH to cortisol. And this cortisol quickly stimulates gluconeogenesis to make new blood glucose. Remember, some cells in the body, brain cells and red blood cells, they have to have blood glucose around all the time. They can't make their own glucose. Like some other tissues, like muscle, can do okay without it around, but not brain cells. What is gluconeogenesis? And we're going to talk about that tomorrow specifically, but it's a pathway that makes glucose from non-food precursors. We know you can make glucose from eating a piece of bread and things like that, but this is using amino acids and fat breakdown products like glycerol, and then even waste from muscle use, lactate. We can use all that to make a glucose molecule, and that's exactly what glucose does. And normally, where's this gluconeogenesis occurring? It occurs normally in the liver, about 90%. The kidneys are also probably 7-8%. Maybe a tiny or contributing, they can make glucose, and a little tiny bit in the intestines too. But during fasting, if you don't have any food, the kidneys actually ramp up quite high, and because they're very good at running gluconeogenic pathways. How does cortisol stimulate gluconeogenesis? Well, because to make glucose, we need a precursor molecule, right? So glycerol is one precursor molecule. So where do we get glycerol? We break down your fat. And so that's where we get it. It can bind with fat cells and cause them to release their lipid content, and it's broken down into fatty acids and glycerols. Glycerol can be used to run through gluconeogenesis, as we'll see. Fatty acids don't. I like that question. Fatty acids cannot be used to make glucose via gluconeogenesis. Muscle proteins are also broke down because all of the amino acids, I like this biochemistry question, every single amino acid and then some that you know can be used to make glucose through gluconeogenesis. Except the two L's, leucine and lysine, can't be used. So great biochemistry question. Maybe one of my questions. It's on the slide, so make sure you know L and L can't be used to make glucose. Then kind of, not maybe perhaps, I mean, it's still important, but maybe kind of in the background stuff is going on that cortisol does. It actually stimulates the making of, or the overmaking of enzymes. Remember all those enzymes you had to learn in the Krebs cycle? Cortisol makes a ton of those things. So this overabundance of enzymes makes sure that oxaloacetate is not wasted. When you get oxaloacetate made, you have plenty of enzymes to run it through the Krebs cycle. Let's see, what am I saying here? So an overabundance of enzymes stimulates and encourages the production of oxaloacetate. But in order to make oxaloacetate, we need enzymes because oxaloacetate is the end product of the Krebs cycle. So we have to make all these Krebs cycle enzymes. So our Krebs cycle is like Superman. Any any pyruvate, right? That's the big molecule that's made by glycolysis. Okay, so you take that and you run it through the Krebs cycle to make oxaloacetate. And now you can run oxaloacetate as a big molecule to run backwards through glycolysis. What's it called when you run backwards through glycolysis? That's gluconeogenesis with a few different enzymes. So we want to make sure the Krebs cycle has plenty of enzymes to take that pyruvate and make oxaloacetate. Oh, there it is right there. I should have just read my slides. So running pyruvate through the Krebs cycle creates oxaloacetate. You can also take the pyruvate and not bother with the Krebs cycle and run it and convert it directly into oxaloacetate. Did you know that little trick? I'll show you that little trick too. See, you're going to learn a little biochemistry here. All right. What else can it do? Same thing, the gluconeogenic enzymes, it can stimulate them to make sure that we have plenty of enzymes for gluconeogenesis as well. All right, so get ready for glycolysis in the Krebs cycle because we're going to go over, gluconeogenesis. That should be gluconeogenesis, for goodness sakes. Glycolysis, we're not worried about. Gluconeogenesis and the Krebs cycle is coming up next. See you later.